Hello and welcome to the Unit 13 presentation on bowel elimination. These are your learning objectives. Please review them in preparation for class and for the exam. So the small intestine, or the small bowel, is about 20 feet long and about an inch in diameter. Its job is to absorb most of the nutrients from what we eat and drink. Velvety tissue lines the small intestine, which is divided into the duodenum, jejunum, and ileum. The large intestine, which is the colon or large bowel, is about 5 feet long and about 3 inches in diameter. The colon absorbs water from waste, creating stool. As stool enters the rectum, the nerves there create the urge to defecate or have a bowel movement. Peristalsis is smooth muscle movements which cause contraction and relaxation in the colon, making the food move. That's why activity is so important. Walking promotes peristalsis by triggering the motility of the colon. The characteristics of normal feces include the following. It's about 75% water and 25% solids. Solids are undigested fiber, fat, bacteria, and inorganic matter such as minerals and proteins. The feces is brown because of the chemical conversion of bile and bilirubin. Bile is made in the liver and secreted to the gallbladder, where it's stored until it's needed to break down the food that we eat. Lots of folks have their gallbladder out. In this case, the bile just goes directly into the small intestine. Bilirubin is formed in the liver from the breakdown of red blood cells. The bilirubin is dumped into the small intestine for removal. People with blood disorders that affect the red blood cells and those with liver problems might experience lighter colored stools. There's a couple lifespan considerations to take into account. Meconium is the intestinal secretions found in the large intestine of the unborn baby. Unlike later feces, meconium is composed of materials that the baby ingests during the time that it's spent in the uterus. This is things like intestinal epithelial cells, lanugo, mucus, amniotic fluid, bile, and water. Meconium, unlike later feces, is viscous and sticky like tar, and it's usually a dark olive green. If the baby has a bowel movement during birth, it's possible that the baby might aspirate the stool. This is called meconium aspiration, and the baby would need interventions to protect their airway. Babies who are breastfed generally have more frequent and thinner stools than babies who are formula fed, and 5 to 6 stools per day is pretty normal. Toddlers work on toilet training and are usually able to hold their stools by about 22 to 36 months. It's common for toddlers to have 1 or more bowel movements per day. School-age children might have constipation from waiting to have a bowel movement until they get home from school. They might be embarrassed to go in public, so they're going to hold it. The longer stool is in the colon, the more water is absorbed from it, and the harder the stool is to pass, and that's why they have the problems with constipation. Older adults have normal changes such as slowed motility, so they need more fluids, fiber, and activity to maintain regular bowel function. Chronic health problems and medications can cause constipation also, and many older adults resort to laxative use to restore normal bowel patterns. There's a few cultural considerations to be aware of. Bowel elimination discussions might be embarrassing to patients, and most patients prefer privacy during bowel elimination, so provide privacy if you're able to. The next several slides outline a variety of things that affect bowel elimination. Think back to our unit on nutrition. A diet high in fiber is found in plants. The 3 major categories are whole grains, fruits, and vegetables. A high fiber diet has many benefits for the colon. It adds bulk and makes bowel movements easier. Some food intolerances, such as gluten intolerance, which is intolerance to wheat, and lactose intolerance, intolerance to dairy, can cause diarrhea or abdominal cramping when eaten. If bowel movements are hard, increase fluid intake and activity. Think about your patient trying to move their bowels when laying in bed. This is not a natural thing, and it might be difficult for them. So raise the head of bed if we're allowed to, or better yet, get them up to the toilet or commode, because that's going to promote a better bowel elimination. So with anxiety, things speed up. This includes peristalsis, which can result in diarrhea. With depression, things slow down. This also includes peristalsis and can result in constipation. Hospitalized patients can be constipated for a variety of reasons, but if patients are embarrassed to have a normal bowel movement or to have any bowel movement, they might hold it in, which is going to result in hard-to-pass stools. Pain or fear of pain can make patients not want to try to have a bowel movement. For example, patients with abdominal surgeries will have a lot of pain when straining to pass stool, so they might be reluctant to use the bathroom. Add to this narcotic use for pain management, which causes constipation also. Additionally, their bowels will be sluggish due to their surgery and anesthesia that was given, further compounding constipation. So we need to be sure to start them on laxatives or stool softeners right away. Increase activity as soon as possible after surgery, and encourage fluids to prevent constipation and make it less likely that they're going to have to strain to have a bowel movement. And with surgery comes anesthesia. The effects of anesthesia include paralyzing the bowels. They go to sleep and they are the last to wake up. That's why post-op patients are typically started on a clear liquid diet until their bowels wake back up. Because if we're putting food into the stomach and the bowels aren't moving it through, they're going to have abdominal distension and maybe even nausea and vomiting. With a fecal diversion, part of the intestine is removed, which leads to creation of a surgical stoma. Stool is collected by a colostomy, which is a stoma using the large intestine, or ileostomy, which is a stoma using the small intestine, and then this is attached to a bag system. Expect the stool to be less formed due to the decreased length of functioning intestines for the waste to go through. Anticipate more watery stool because less water absorption goes on in the intestines. The more bowel that was diverted, the more loose and watery the stool will be. Likewise, the closer to the rectum the ostomy is, the more formed and less watery the stool is going to be. So there's several altered bowel function problems. The first here is constipation. Constipation can be a problem for many patient populations. The defining characteristics of constipation are listed on the slide. So what can you do about it as a nurse? Well, education that you can provide is going to be the basis, and this includes things like increasing fluid and fiber intake, increasing activity, which promotes peristalsis, and also the client can use stool softeners if they're ordered. Fecal impaction is another elimination problem. This is accumulation of hard feces in the rectum, and the patient cannot get it out with a normal bowel movement. Liquid stool can ooze around the site of impaction. Treatment should start at the top and work down, and that means taking fast-acting laxatives. Question the underlying cause. Is it related to cancer, medications, poor nutrition, or elderly with decreased motility? Consider a bowel regime for the elderly as an intervention. Bowel regimes consist of home remedies, diets, and medications. The next on the list is diarrhea. Anticipate that diarrhea stools are very acidic and cause soreness, inflammation, and bleeding. Think about the last time you caught a GI bug and how miserable you might have felt. The patient with diarrhea is at risk for skin breakdown. So implement skincare measures such as barrier cream and clean soiled skin as soon as possible. We don't want them sitting in this acidic stool and having it on their skin. Patients can develop C. diff infections when taking antibiotics for another infection. The antibiotic kills the normal bacteria in the gut. This prompts the growth of C. diff, which grows without the normal gut bacteria to destroy it. C. diff is also ingested by spores by the fecal-oral route. The C. diff spores can live up to 2 years on inanimate objects, and hand washing is needed to eliminate the C. diff spores. Hand sanitizer does not work. Fecal incontinence is the next problem, and this is being unable to hold your stool. Fecal incontinence can be caused by spinal cord injury due to decreased nerve supply or lack of sensation to the area, or with a weak pelvic floor. Incontinence can occur when the urge is too strong, like when the patient has diarrhea and can't get to the bathroom in time. Confused individuals may have no inhibitions and might just have bowel movements in public whenever the urge presents itself. Flatulence is the accumulation of gas. Swallowed air can happen with improper use of drinking straws, or swallowed air happens with anxiety reactions. Think about a patient that might be hyperventilating. They're swallowing a lot of air. Since gas is typically absorbed by intestinal mucosa, a disruption in the balance of bacteria can produce excess gas. Foods considered high in the ability to accumulate gas includes cabbage, beans, and high-fiber foods like whole grains, fruits, and vegetables. Gas can be diffused from blood due to the interaction of ions during the breakdown of red blood cells in the intestines. One thing to remember and reassure your patients, gas is normal. An interesting fact is that the rate of excretion of gas ranges from 200 to 2,000 mils per day. That's up to 2 liters of gas. Distension is bloating or swelling of the abdomen. Obstruction can be temporary, like with an ileus where the bowels are not moving. There's no peristalsis. This resolves with resting the bowels. Bowel rest is performed by placing an NG tube through the nose into the stomach and hooking the NG tube to suction, which keeps the stomach empty. Obstruction can also be in the form of bowel obstruction. This can be due to a blockage, ischemic bowel, or bowel dysfunction. Treatment is typically bowel rest initially, and if it doesn't resolve, then the patient's going to need surgery to remove the blockage. One of the best interventions for people whose bowels aren't working well is activity. Activity promotes peristalsis. This is why activity after surgery is so important for our patients. So if we're going to use the nursing process to develop a care plan, remember we start our care plan with the assessment. This includes both subjective and objective data. We want to get a good understanding of the patient's normal bowel function and if it's different now from what their normal is. With the exam, we look first, then listen, then feel for areas of tenderness. We look first in case there's any pulsing masses in the abdomen. We don't want to press on these because they could be aneurysms. We listen to all 4 abdominal quadrants for bowel sounds. It's important to palpate last because it can change the bowel sounds that are there. Tenderness can be related to constipation or bowel obstruction. Also, pain and tenderness in the low abdomen can be caused by appendicitis, ovarian pain, pelvic inflammatory disease, or hernias. Think about what your assessments mean. Measuring the circumference of the abdomen or abdominal girth is a way to track distension to see if it's getting worse or better. We also want to assess stool characteristics. This includes frequency, consistency, and color. And we put all of these together, to get a big piece of the picture and to know what our assessments mean. And we don't generally just say one thing, like we just listen to bowel sounds and we ignore all the rest. We want to, put our assessments together and look at the big picture. All right, well, now talk about some diagnostic tests your patients might need if they have an alteration in bowel elimination. Hemoccult or fecal occult blood testing involves placing a small smear of stool on a card and applying developer. If the color changes, there's hidden blood in the stool. Frank blood is visible blood on the stool. This can be from gastrointestinal bleed, hemorrhoids, or cancer. Stool cultures check for infections in the intestines. Barium enemas make the GI tract show up better on x-rays or CT scans. If a patient has a barium enema, it's essential to monitor for bowel elimination. Barium is very constipating and can cause an obstruction. Encourage the patient to drink plenty of fluids to promote passage of the barium. Endoscopy means looking inside the body with a tube with a camera on the end. A colonoscopy and flexible sigmoidoscopy are a common test used for screening and diagnosing colon disorders. A tube with a camera on the end is inserted through the rectum and into the colon. The colonoscopy allows the provider to view the entire colon, while the sigmoidoscopy is a shorter tube and allows the provider to view only the sigmoid colon. Possible nursing diagnoses for altered bowel elimination include constipation, diarrhea, perceived constipation, or incontinence. We want to set our goals and remember to make our goals patient-specific, measurable, and realistic. Remember that nursing interventions are simply how you will accomplish your goals. What will the nurse be doing for the patient to help with alterations in bowel elimination? Interventions like encouraging activity and fluids or educating the patient are always appropriate, or usually always appropriate. appropriate, provided the patient doesn't have a dietary restriction or a fluid restriction. The type of laxative advised to use depends on the unique circumstances of the patient. What effects do the various laxatives have? What are the underlying reasons for the constipation? Are there any other medical conditions? For example, people with renal disease should not use milk of magnesia. Milk of mag contains a lot of magnesium, which we know from our unit on electrolytes that renal excretion is the major route of magnesium elimination from the body. If the kidneys are not working correctly, magnesium can build up. A buildup of magnesium can cause heart arrhythmias because the magnesium blocks calcium. Bulking laxatives, such as Fibercon, add bulk to the stool and make it easier to pass. Emollient laxatives, such as Docusate, lubricates the colon and makes stool easier to pass. Saline laxatives, such as milk of magnesia, draw water into the colon to soften the stool and make it easier to pass. Again, monitor for renal disease with magnesium-containing laxatives. Stimulant laxatives, such as X-Lax, work by stimulating intestinal mucosa to make the stool come out. And these can cause some pretty significant cramping, so kind of keep that in mind with your patients. Kaopectate and Pepto-Bismol work by absorbing bowel irritants and extra fluids from the intestine. They turn stool black. Bulk-forming agents like Metamucil work to absorb extra fluid in the intestines and add bulk also. And this leads to more natural bowel movements, or more normal bowel movements. Opiates and synthetic opiates like Imodium slow motility or cause excess fluids to reabsorb in the intestinal wall, increasing or decreasing diarrhea. Antispasmodics decrease motility. As stool movement slows down, there's more time for water to be absorbed out of the stool, and the result is a more formed stool. So if your patient has complaints of being overflatulent or too much gas, over-the-counter meds like simethicone combines gas bubbles together and can help them move out of the GI tract. Enemas are something inserted directly into the rectum, and this should not be used on a regular basis. We should only use it if laxatives don't work. Again, we want to start from the top and work our way down when we're dealing with constipation problems. Enemas can distend the bowel because we're injecting fluid into the rectum. The solution is hypertonic, so it osmotically draws water from the colon mucosa and into the stool. Tap water enemas should be warm water. Cold water is going to cause some bad cramping for your patients. For fecal impaction, removal might be necessary to give, and before we do this, we probably should think about giving the patient pain medications or relaxants if they're ordered, because it's very painful to have digital disimpaction. This is where the nurse puts a gloved finger, lubricated first, into the patient's rectum to manually remove the stool that might be stuck. And then a rectal tube insertion can be done to relieve gas. And fecal collection tubes are soft tubes that are inserted into the rectum to collect liquid stools. Know that bacteria growth can cause infection. Stoma care is a nursing specialty, especially with new stomas from colostomies and ileostomies. Typical care includes burping the bag, which is relieving it of gas, removing and emptying the colostomy bag, cleansing the stoma site, and applying a new device and bag. Specific bowel training programs are done depending on your client's condition. Bowel training is an attempt to create a regular routine for bowel elimination and is especially helpful for patients with neurological impairment, such as those who are paralyzed. Next, we evaluate if our goals have been met. If not, restate the goals and interventions with needed revisions. And this is an example of a nursing care plan for a patient with constipation. Review it closely for a good example of how to properly write a nursing care plan. This can also be found in your Craven text. This concludes the presentation on bowel elimination. Be sure to view the presentation on urinary elimination as well. And thanks, and have a great day.